Okay, so let's get started while the colleagues will arrive. And so I will, we keep these talks 10 minutes because then we want to have a lot of discussion afterwards. So we know that heart failure is a continuous process and starts with risk factors. So when we look at phenotyping, we always have to look at what are the risk factors behind the disease, and so identify which of the risk factors are the most prominent. If a patient has ischemic heart disease, probably will develop an ischemic, left ventricular dysfunction and heart failure. If it's hypertensive or obese, probably will develop heart failure with preserved ejection fraction. But what is important, and we've learned, is that we can slow the progression of heart failure by acting early. So first point is to detect early and prevent using prevention therapies. For many years, we've been used to think of heart failure as heart failure with reduced ejection fraction, because these were patients where most of the research has gone, where most of the drugs were. But if you look at all the epidemiological evidence, it shows that only less than 50% of patients with heart failure do have a reduced ejection fraction, whilst the vast majority, and that is due to increase, have a preserved ejection fraction. So going towards the definition of heart failure, there are many definitions, but all of them are concordant on the fact that we need sign and symptoms, evidence of congestion, and we can get that evidence of congestion by using natriuretic peptides. Then when we need into refinement of diagnosis, then we can use echocardiography, but that is not to confirm the diagnosis. That can be confirmed by using peptides and history and the symptoms, but mostly to phenotype patients to detect whether they are reduced, preserved, and are possible other causes of the disease. And so you can see that in the European guidelines, the NT-proBNP plays as a very important and prominent role, more than other forms of interventions. And when we look at the cardio guidelines, the guidelines probably are the most outreach guidelines, because they're developed not just for the rich countries like maybe UAE, Europe, some parts of Europe and America are, but it's more global guidelines that will tell you what to do in all different settings. You see that there is a strong recommendation for the use of natriuretic peptides in the diagnosis of heart failure. So that is followed by the use of TTE, in order to detect and identify the profiles. But also then identify patients that may be at a specific risk for heart failure. So in the diagnosis of chronic heart failure, the natriuretic peptides are indicated as a central diagnostic tool in order to identify those patients who won't have heart failure and those who are at increased risk of having heart failure. So in the past, we used the guidelines to say if NT-proBNP is below 125, then we can rule out the heart failure. But we didn't have precise values or cutoffs to identify patients who will have heart failure. And this is a position paper we published a few years back, where we identified different thresholds according to the settings where you see patients. So you see, you can, even in the emergency department, in a patient that it's sort of wet, you can rule out with certainty the heart failure is the NT-proBNP is below 300. Then if it's above 450, you need to use the age-adjusted rule with, if a patient is less than 50, use a threshold of 450. If it's between 50 and 74, 900. And if it's greater than 75, 1,800. So these cutoffs identify patients where heart failure is highly likely. And in the outpatients, of course, we can use different thresholds. And these are still, you can see here, the age-adjusted rule in patients with according to age. Of course, on top of that, we have to take into account the presence of obesity that may reduce the NT-proBNP, but also the presence of renal dysfunction that may increase the NT-proBNP as the atrial fibrillation. The other problem is that we've made it too complicated. In 2016, there's been the introduction of the heart failure with mildly reduced ejection fraction, but we have to take into account, even in the best hands, the echocardiography as a measurement error. That is around 10%, no matter what. And therefore, there will be overlapping features between reduced and mildly reduced, preserved and mildly reduced. Probably what we'll see with the next guidelines is that we will move towards a threshold of 50% with mildly reduced ejection fraction being reincorporated into the reduced ejection fraction, but still those patients between 45 and 55 will remain a gray zone. So what is more important rather than identifying the precise ejection fraction is to look at how the left ventricular function changes over time. Because we may have a patient with preserved ejection fraction with left ventricular function remains stable. Other patients that will go towards mildly reduced or reduced. And in these patients, we don't have to wait until the left ventricular function is very reduced before introducing therapies that we may want to use for heart failure with reduced ejection fraction. So the left ventricular trajectories are more important compared to the singular assessment of left ventricular function that may change in a few months. And as that change, also the treatment may change, and you can see that we have evidence from, and this is a very nice paper that just came out on the journal Cardiac Failure, is very accurate. I suggest you to read it, and suggests all the different interventions according to the different degrees of reduced ejection fraction. So how we have to interpret the guidelines? Probably we'll have changes. I mean, probably some of these changes will be on the left ventricular function, the 50% cutoff, but also on how we will look at the therapy that we will change from pillars to foundational or additional. And then we have to incorporate into that also the different phenotypes according to heart rate, atrial fibrillation, iron deficiency, worsening heart failure, different heart rate, blood pressure, and also integrate the devices. For preserved ejection fraction is different because we know that in preserved ejection fraction, comorbidities are more important. So for whilst in those patients with reduced ejection fraction, we need to look more at the, some of the comorbidities, but mostly the presentation, heart rate, renal function, blood pressure, and atrial fibrillation. In preserved ejection fraction, we know that we have to use the SGLT2 inhibitors and the MRAs, but then the additional therapies should be targeted according to the comorbidities, and these are some of the drugs that can be useful according to the different comorbidities. So in order to stay within the time, I think we need to keep the diagnosis of heart failure using signs, symptoms, and if there are elevated NT-proBNP, then we can start patients on therapy. Of course, until we don't know what the left ventricular function is, we have to start only those two medications that have been approved all across the left ventricular function, which are the SGLT2 inhibitors and the MRAs. Use diuretics if there's congestion, then perform the echocardiography, and once we have the echocardiogram, treat according to the left ventricular function, but at the same time, assess the comorbidities and treat according to the comorbidities. Thank you very much for your attention.
Excellent. Thank you very much.